Hello, thank you for joining our September MMS info session. These sessions are offered under the CMS Measures Management System contract led by Battelle. I am Kate Buchanan and I support education and outreach efforts on this project. Today's session is on CMS's Quality Improvement Program. Next slide. These info sessions are part of an ongoing effort to engage measure developers and other stakeholders in quality measurement topics. As you can see here listed, some of the other activities that the MMS team engages in. I will now turn it over to Anita.
In quality, along with our sister group, QIIG, and QSOG, SOG, and others. Also, organizationally, we are located, our staff, we have over 100 staff that are located in Baltimore and various locations across the United States. They all serve as quality improvement leaders that are responsible for healthcare quality improvement in nursing homes, hospitals, communities, dialysis facilities with the American Indian Alaska Native population, and we have, separate opioid outlier prescriber work that's ongoing as well. We also have a large program for it's the BFCC, which is the Beneficiary and Family Centered Care, which is the beneficiaries advocacy program and provides beneficiary protections and oversight as well. So for today's call, I'm joined by my team here, Colleen Frey, who's the acting director of the Nursing Homes and Community Health Program, Shawan Johnson, who is the acting director of the Hospital Quality Improvement Program and the AIAN IHS, opioid outlier program that I mentioned, and Shalon Quinn, who is the director of kidney health, and also leading data initiatives across the group. So I wanted to start off, and we can move to the next slide, please, with providing some perspectives. Could we move to the next slide, please? Thank you. So just providing some perspectives on the role of quality improvement in CMS, which is, primarily seen as, in addition to being a public health agency, is being a strong sort of regulatory payment agency. So here we are in quality improvement, which in our programs where we work voluntarily, right? The providers that work with us work voluntarily with us. There is not a payment incentive or a regulatory teeth or compliance stipulations for them to work with us. So it's almost completely voluntary. And so the role of quality improvement in an agency like this is really, really important to understand because of the nature of the work, but also because it has evolved over time. So the way that we accomplish our work is through what we call quality improvement contracts. And you have different names that you may have come across, the QIO, which is Quality Improvement Organizations that Colleen leads, that work with nursing homes and hospital and communities. And then Shawan leads what we call the iQuIIGs, which are the hospital quality improvement contractors. They are not QIOs, they're hospital quality improvement contractors that work in that space. And then, of course, Shalon leads the ESRD networks that work with in the kidney health space. And so the contracts run over 5-year periods or terms, and we call them scopes of work. We are currently in the 12th scope of work, which started for the nursing homes, communities, and hospitals in 2019, and will end in 2024. And we're also in the midst of planning for the 13th scope of work, which begins in 2024 and ends in 2029. So they are 5-year terms of work that include quality improvement initiatives. We recently redesigned the quality improvement programs to do a couple of things that are stated on this slide. One is to better align with other levers within CPSQ, specifically with measurement and enforcement. And I'll talk about that a little more. And second is to provide targeted focus of QIO resources and financial resources on providers that need it the most. So, small, rural, vulnerable populations, low-performing providers identified from measurement data and enforcement data. The pandemic obviously put us back in the limelight, where the QIO program, and we're really fortunate that we could do this and respond effectively, was seen as the rapid response arm of CMS, providing, technical assistance and training to frontline nursing home staff and managers and, hospital staff and management as well. Being one of the largest federal programs devoted to quality improvement, we have a huge sense of responsibility and accountability. And that is infused throughout various aspects of the program, whether it's the design of the program, whether it is outcomes-based payments. These are contractors that are paid for payments achieved, for outcomes achieved, and through our, frequent monitoring and evaluation. That's a part of the payments as well. That's part of the accountability as well. Also want to say just a little bit about innovation. We had not been able to focus on innovation entirely in the first 2 years of the program, which was, through 2020 and 2021, because every day was innovation for us in quality improvement through the pandemic and sort of learning our way through a cycle of iterative changes that needed to be made in the way that we approached, the quality and safety gaps that we saw in nursing homes and hospitals. But starting fiscal year 23, we will be working on certain key innovation projects related to health equity, related to new models of technical assistance, just so we could better understand on a small scale, how to design an effective quality improvement package before we can make a large financial investment in that space. Next slide, please. So before I turn it over to Colleen to go over, the nursing homes program, and what you're really going to hear from the directors that are here today is they'll give you an overview of the goals in each of their programs. They'll give you an overview of the measures that we use to drive, quality improvement or base the quality improvement strategies on. And what we're hoping is that this will be a starting point for the discussion to take place. I know it's hard to sort of figure out where to start and how much information to provide, but I see this as the beginning of an important and critical conversation. And we'd be happy to take your questions, after, and then also be available for any follow-up, presentations or meetings as the case may be. But I wanted to, before I turn it over to Colleen, just share a couple of things around why this partnership between us is very, very important from both an improvement standpoint and with you all as the measurement community. So measurement is a critical part of quality improvement, right? It helps us, it helps quantify healthcare processes and outcomes, and then provide us with the data that we need to base our quality improvement efforts on. We use your data, the measurement data that you all, help bring about to identify opportunities for improvement, to help us build that quality improvement framework, that will help us systematically improve care. So this partnership is very important, and we need to continue staying aligned, just as we've done in the redesigned 12 scope of work, where we use the measures that are available, tested, tried, and implemented, through regulation, that we use those measures in our programs, and we use the data that measurement provides. Alignment is obviously great for a number of reasons, and a couple things that come to mind for me are, the first just being the impact to, I would say, health outcomes and the patient experience is synergistic if we can align the measurement and the improvement, side of the house. We can exponentially increase the impact that we can have, that CMS as an agency can have in the quality safety space. And then the second part that I would say really is the use of that measurement data that's really important to us. I know that, we've all heard that you can't improve what you don't measure, right? And I want to flip that a little bit too, to say, let's focus on measuring the things that require improvement. There are sometimes a lot of measures that can organically and naturally be used within quality improvement programs, and then some others that maybe we're not able to use to that extent. And so would like to continue that conversation to have that meaningful alignment between the measurement, the focus of measurement and the focus of improvement, so that we can focus on those gaps and what needs to be measured and how we can then translate that data that comes out of it into or build on that data to deploy quality improvement interventions that are likely to change behavior and are likely to provide us with outcomes. And so, speaking of outcomes, we have the same goals, right? And that goal is really to improve, outcomes for our patients and improve the patient experience. And so, thank you again for having us here today. Happy to continue this conversation with you all. And with that, I will turn it over to Colleen Frey, who's the director of the Nursing Homes and Community Program, which is a QIO program. Colleen, over to you.
Thank you, Anita, and thanks everyone for inviting us. I share Anita's enthusiasm in working with all of you to help improve care to our beneficiaries. So as Anita mentioned, I'm the acting director over the division that works with nursing homes and with the populations in community health. And in the nursing homes, CMS works with Quality Innovation Network Quality Improvement Organizations, or QIOs as we commonly call them, to provide technical assistance and training to nursing homes. So we have our primary goals here, and one of the most important things is that it's important that we have flexibility to shift our goals when necessary, such as during public health emergencies. As Anita mentioned, the actual scope of work was mapped out prior to the pandemic, and then once we were hit with the public health emergency, we had to quickly shift and focus on reducing harm to our nursing home residents during the pandemic. So for the past couple of years, our goals have really focused mostly around, as I said, reducing harm to the residents and the staff in nursing homes. And we have some other goals kind of still chugging along in the background, but these have been our focus. So what our primary goals are around, obviously, is controlling and reducing the spread of COVID-19. Some of the ways that we've done that is to make sure that frontline staff and managers have been adequately trained for infection prevention, especially in light of a novel disease that we had not seen before. This includes technical assistance from the QIOs to the nursing homes, where they actually went on site, evaluated the infection control program in the nursing home, and then worked with administration to improve their infection control practices. Obviously, doing this would increase resident safety and reduce harm. And then the other piece of that was that we provided vaccine help. So that help came in many ways. The QIOs helped to procure vaccines where they maybe were not as available as in some other areas, so they helped procure it. They also helped to set up on-site and mobile vaccine clinics and booster clinics so that they could go directly to the nursing homes or close by to make it very easy and convenient for the staff and residents to be vaccinated. And then they also worked with vaccination to reduce hesitancy. So there was, as most of you know, there was some hesitancy around the vaccine and booster, and they worked very closely with the administrators in nursing homes to reduce that hesitancy. And then the other piece that we've always continued to work on, because it is so very important, is improving the quality of care transition. So a patient or a resident in a nursing home may frequently go to other avenues of care. They may need to be transferred to their primary care physician, for instance, or unfortunately hospitalization. And we work very hard to make sure that all of those transitions are done as carefully and safely as possible for the residents. Next slide, please. So these are the nursing home core measures. As I said, even as we've moved through our pandemic response, our entire focus remains on increasing patient safety and reducing harm from preventable events and during transitions of care. So the specific goals that we have here, the first goal is around reduction of COVID-19 infections, and the measures related to that are, of course, vaccine and booster uptake, whether or not the nursing home had established policies around visitors and resident cohorting, whether they had an emergency preparedness plan that was localized to their nursing home to adequately address any emergencies, including the pandemic, and then also being part of COVID-19 Learning and Action Network so that there was training out there for them to be able to take. And then again, as I talked a little bit about the infection prevention training, CMS approved infection control and prevention training using many resources, most especially those provided by the CDC as the source of truth. And then other patient safety efforts that focus on reduction of harm are around reducing C. difficile infections, which we know can be very serious, especially for nursing home residents, reducing adverse drug events, and reducing hospitalizations related to all infections. And in here, in this measure, we did count in COVID-19 infections as well. And then finally, increasing the quality of care transitions. One area we look at is all-cause readmissions to evaluate why the patient was readmitted to the hospital and whether or not they were safely discharged previously. And then also measuring any preventable incidents that result in emergency department visits for the residents. Next slide, please. The other area that is really exciting to work in, and again, I feel very privileged to do, is in the area of community health. So again, CMS directs the QIOs to provide technical assistance and training to providers and community partners. And those partners can vary based on the region that the QIOs are working in. So it can be, for instance, the Area Council on Aging, or we've seen great success in some areas working with the churches and their ministries. Other health departments, obviously providers, and anyone that provides care to our beneficiaries when they're out in the community. We, of course, continue to emphasize increasing safety and reducing harm, and our QI here is directed to the highest needs of the beneficiaries as they're out in our community. So in this case, we did do some work, again, around COVID, getting some information out about vaccines and so forth, but our primary goals here in the community were reducing the harm from opioid use, and there were a couple of areas where we focused on there. Especially around how opioids are prescribed and reducing harm from them. Again, we are looking at transitions of care, so we want to coordinate care in the hospitals and emergency departments, again, to make sure patients are discharged safely and that they do not have unplanned returns to the hospital or emergency department for various preventable incidences. We also look here where it's very important at the health of our beneficiaries who have chronic conditions. As we know, if we can manage to keep the chronic conditions at a manageable level, it reduces the need for the patients to have a more serious illness or be hospitalized or end up in the emergency department. And then again, increasing readiness for public health emergencies. Next slide, please. And these are the goals and the core measures that are around the goals in community health. As I said, care coordination, again, obviously emergency department visits and hospital utilization. Hospital utilization is mostly, again, around safe discharges and readmissions. Opioid utilization, so we look at adverse drug events for opioids and how those can be prevented, and then share opioid best use practices with physicians and other providers so that they know how they can safely prescribe these very dangerous, really, drugs to their patients with reducing the opportunity that the patients will be harmed by the opioid use. Again, emergency preparedness. So we look at to make sure the providers in healthcare facilities in the communities have an emergency preparedness plan, again, localized to them, because we have seen in the past that it's not unusual for nursing homes or some community providers to have what would be considered an off-the-shelf emergency plan that may not take into account the most frequent emergencies that happen in their areas, flooding, for instance, and how they would deal with patients. So we want to make sure that the emergency preparedness plans are specific to those providers. And when we're looking at chronic disease management, we've chosen 4 areas that we thought would be probably most helpful in managing chronic disease out in the community. 2 of them are around cardiac issues. One is controlling the patient's hypertension and making sure they're getting treatment for that to obviously reduce incidences of heart attacks and stroke and kidney disease. The other area we're looking at is outpatient cardiac rehabilitation when the patient has had a cardiac incident and making sure that they get back to as close to their baseline as possible after the incident. We look at reducing diabetes and then look at ways to help prevent kidney disease. And then finally, because this is an important patient safety measure, we have measures around increasing vaccination and booster rates. So programs that would increase influenza vaccination among beneficiaries, pneumonia vaccinations, and then COVID-19 vaccinations among our beneficiaries. And I think I am turning this over to Shawan now. Thank you.
So it looks like we are having difficulty hearing Shawan. Should we move forward to the next presentation and then we can circle back?
Sure, that makes sense. This is Anita, so we can move to the next segment. And if Shawan still has difficulty getting on, I'm happy to, take over the segment for her. Thank you.
Thank you. Next slide.
All right, I can take this section. This is Shalon Quinn. Can you all hear me?
Yes.
Perfect. All right, so I'm Shalon Quinn. I'm the director of the Division of Kidney Health. So in our division, we really focus on quality improvement in dialysis facilities and transplant centers to improve care for people with end-stage renal disease. So we have 2 major programs that we focus on in this division, the ESRD Network Program and the ESRD Treatment Choices Learning Collaborative. So the ESRD Networks, it's a statutorily mandated and funded program to help improve care for dialysis patients. And we do work with all dialysis facilities in the country, not just a cohort of them. Then the second piece is the ESRD Treatment Choices Learning Collaborative. So the Innovation Center at CMS, they developed the End-Stage Renal Disease Treatment Choices, which is ETC for short. It's a payment model with one of the goals of that payment model is to increase kidney transplantation nationwide. And as part of the rule that went out, there was a learning collaborative that was designed and developed. And so iQuIIG does oversee that learning collaborative piece of it. More acronyms here. We call it the ESRD Treatment Choices Learning Collaborative, so ETCLC. And in the development and the administration of this contract, we collaborate really closely with the Innovation Center and with HRSA for that oversight and direction for the collaborative. So the collaborative brings together all of the players that are in the transplant space. So that's going to be organ procurement organizations and donor hospitals, transplant hospitals, patients and families. And they have recruited 80% of all transplant centers in the nation, 80% of OPOs, and 2 donor hospitals per OPO. So it's a large collaborative bringing together the entire community. And then as part of that collaborative, we do review data. We identify the highest performers in each one of these areas, and we spread those best practices from the high performers across the transplant community. Next slide. So we'll start off by focusing on the ESRD network. So the ESRD networks are kind of analogous to the QIOs, the Quinn QIOs that Colleen was just talking about. They do improvement work. It's a series of contractors that do improvement work for in dialysis facilities, focusing on increasing the quality of care for dialysis patients. So we have a lot of different metrics, but for the purposes of this slide, we'll kind of put them in some buckets here. So the big areas that we focus on are behavioral health, patient safety, home dialysis, and transplant. So you can see here we've got screening for and treatment of depression. We, especially with COVID, there's really an increase in depression amongst this community. A lot of people, are very isolated because of their ESRD. So we're focusing on making sure we're appropriately screening for and referring for treatment of depression. We are working in the patient safety area on decreasing hemodialysis catheter infection rates and also the incidence of peritonitis. So focusing on those access sites and reducing infection there. And we're working on increasing incident and prevalent patient usage of home dialysis. So making sure people are either starting on home dialysis or switching to home dialysis. Obviously, patient choice of home dialysis, but really making sure patients are educated on benefits of home dialysis. And then, as it's works very well with our other program that we'll talk about here in a second, but we do work in the ESRD networks on kidney transplant. We know that kidney transplant is, the primary method of really increasing patient quality of life for ESRD patients. So we try to increase those that are on a wait list and the number of actual patients that are transplanted. And then another piece of patient safety here is vaccination, obviously. We do focus on pneumococcal, flu, and COVID vaccination. COVID vaccination focusing on patients and on staff as well. And then very similar to what Colleen presented for the nursing homes, we focus on decreasing hospital admissions and readmissions for specified diagnosis codes. One other thing, as Colleen was mentioning for the nursing home program, we also really have a strong focus on infection control to reduce the spread of COVID-19 in dialysis facilities. So this does include technical assistance to clinics that are experiencing increases in COVID cases, and then, as I said here, COVID vaccination efforts for staff and patients. Next slide. So the second major program that we have is the ESRD Treatment Choices Learning Collaborative, and we really have three buckets of metrics here too, three aims we call them. So the first aim is our transplant aim. As you can see here, we're focusing on increasing the number of deceased donor kidneys that are transplanted. The second aim that we have is our discard aim, and there's actually two measures in there. So let me kind of outline those. We're working on decreasing the discard rate of procured kidneys with a KDPI, which is the Kidney Donor Profile Index score, that's greater than or equal to 60. And then we're decreasing that discard rate of procured kidneys that are below the 60 KDPI as well. We just have different metrics for each one of those kidney types. And then the third aim that we have is it's our recovered kidney aim. So we're focusing on increasing the number of deceased donor kidneys with a KDPI greater than 60 that are recovered for transplant. We know that those higher KDPI kidneys are the ones that are not used very often, and they really could, in some circumstances, increase transplant rates, increase quality of life, and help some avoid dialysis, and really focus on this preferred method of kidney care. Next slide. I think that was my last slide, so we may go back to Shawan.
And Shawan, we are still unable to hear you.
I'm giving her a couple more seconds here. I'm not hearing her still. So let me go ahead and take this one, Kate. I'll just go over it briefly before we go into question and answer session. But This is the hospital program. It's a 4-year program that began in 2020, and ends in 2024. We have focused the entire program on about close to 2,000 hospitals. I believe it's 1,948 or so. Hospitals that are small, rural, include critical access hospitals, and provide care to vulnerable populations. So I believe it's a total population there served by these hospitals, about 1 million Medicare beneficiaries. The 3 important goals of this program are to improve behavioral health outcomes with a focus on decreased opioid misuse, increase patient safety with a focus on reduction of harm, and then increase the quality of care transitions. Next slide, please. So these are some of the core measures that we use in each of these areas. I'm not going to go over each one of these by name, but I will share some work that we're doing in the hospital program, just in terms of some of the outcomes that we're seeing. Obviously, as you can imagine, or if you've looked at the data generally, we've seen our quality improvement contractors have made a lot of gains in the behavioral health outcome space with opioid prescribing and adverse drug events, not just because of the quality improvement efforts in that space with the enrolled hospitals, the about 2,000 hospitals or so, but also because nationally there's been a significant decline in the number of opioid prescriptions, and also deaths due to overdose not being attributed to opioids as much. There has also been a significant gain that's made in the quality of care transitions around readmissions, and I think that some of that has to do with the kind of patient mix that's been admitted to hospitals and the need for, that has eliminated some of the need for readmissions there. However, what has been concerning to us, which is not news to everyone, is just the declines in patient safety that we're seeing in our program, but also in the hospitals that are part of our program, also generally in the national, landscape. And this was, declines that we're seeing pre-pandemic as well. And so we did a midpoint patient safety reassessment in our program that included a very rapid cycle qualitative, quantitative analysis of some of the data to identify resilient, non-resilient hospitals. We also held listening sessions recently with some of the large national stakeholders in the patient safety space, including IHI, the American Hospital Association, America's Central Hospitals, and others, and Joint Commission included as well. And so we've received a lot of great feedback from all of these stakeholders, just in terms of, one, their experiences on the front lines with the challenges around patient safety, which were really important for us to know. And second is recommended, potential solutions for how to design a quality improvement package that is responsive to the challenges that are faced now, especially given that this program, and I think Colleen mentioned this for her program as well, the hospital program was developed prior to the onset of the pandemic and awarded during the pandemic. And so there's a little bit of shifting and pivoting that needs to be done in this space. And so we're there in that zone right now, and hopefully we'll have some direction in the next 2 to 3 months or so. Next slide, please. So this is the American Indian Alaska Native Quality Initiative, working with service units with the Indian Health Service. We have close collaboration and partnership with them, working with their hospitals and critical access hospitals and service units there. 3 primary goals, again: improving behavioral health outcomes, increasing patient safety with a focus on reduction of harm, and increasing quality of care transition. We are making gains in these areas with the AI/AN population, and then really looking to take some lessons learned, and the insights for future program improvements. Next slide, please. These are some of the core measures in the AI/AN space. Next slide, please. Okay, and this is the Support Act work, supports Section 6052 of the Support Act, where we work directly with providing technical assistance to outlier prescribers of opioids. I mentioned a little bit, earlier, just in terms of the evolving landscape around opioids in the country, and so since the opioid prescribing has declined, and since the statute here is pretty limited in terms of working with outlier prescribers, we are working with a very small pool of, a couple hundreds, I think about 400 or 500 outlier prescribers of opioids at this time. We get our list of outlier prescribers from CPI, the Center for Program Integrity, and iQuIIG provides the technical assistance through a national contractor. The goals of the program really are to educate, provide training, to outlier prescribers of opioids on best practices, non-opioid pain management therapies, and how to reduce those prescriptions. And so that's been, we have some challenges in this program, not just because of the limitations from the statute that focus us on a very small group of providers, but also because those providers themselves are, it's a very small group. It's recalcitrant. There are a number of challenges out there with being able to work with them, have an effective outreach and communication, and then provide the kind of technical assistance that they need. So we're in the midst of program reassessment on this program as well to see if there are some short-term actions that we can take to be more effective, and what that might look like, as well as sort of thinking about the long term. Next slide, please. I believe this may be some of the measures that we're working on in the program. Next slide, please. Okay, so I think that brings me to the end of Shawan's section of the presentation. Kate, I will turn it back over to you. Thank you.